and I'm joined by a really wonderful panel here today. As Mental Health Awareness Month comes to a close and we start to move into June, which is Gun Violence Prevention Month, this is a incredibly important time, I think, that we talk about the intersections of mental health, gun access, and suicide, particularly in this era of COVID. We knew that in March and April, there were unprecedented numbers of background checks for people looking to buy guns, and that there are research is showing us and polling is showing us that there are many new gun owners out there. We also know that there's been quite a bit of social and physical isolation as a result. There's economic uncertainty that's going on. There's uncertainty about the future. And now we have this added layer in many places of fear and anxiety about what actually we should be doing with regards to things opening back up, which is adding, I think, another layer to this conversation today. So over the course of the next 45 minutes to an hour or so, we'll see how long people want to stay engaged. We're going to have this great discussion. Just by a way of some sort of rules of the road of how we'll be doing things, if you have questions for our panelists at any time, please either use the question and answer function in Zoom or just post them in the comments on Facebook if you're joining us on Facebook. And we'll get to those after about 20 to 25 minutes of some moderated discussion that we have going on. So please put those in at any time. And if we don't get to any of your questions, we'll be sure to answer those questions in the Facebook comments and solicit feedback from our panelists. So don't worry, we will make sure that all of your questions do get responded to you. And thank you so much for joining us today. So as I mentioned, I'm Kyleanne Hunter, and I am joined by three great panelists. The first of which is Arkaprava Deb, who's with Doctors for America. He's a psychiatrist in New York City and specializes in young adults with severe mental illness and emergency psychiatry. He teaches residents and medical students at SUNY's Downstate College of Medicine and NYU School of Medicine. His other specialty is preventative medicine, which I think is really important that we're talking about today, which required training with the state health department, managed care organization, and he's also a health policy analyst think tank and a very large employer's occupational health and safety division. He's been a visiting fellow at the Urban Institute's Health Policy Center and a public psychiatry fellow at Columbia University with New York State Psychiatric Institute. He also conducts workshops to educate the public on mental illness and mental health resources and advocates at the local, state, and federal levels for gun safety measures. And he's going to be talking a lot today about resources and how to really get resources in the hands of the people who need them the most. I'm also joined by Mike Anestis, who is the incoming executive director of the New Jersey Center on Gun Violence Research, which will be starting July 15th. He serves as an associate professor at the Urban and Global Public Health at Rutgers University. And his research focuses on suicide prevention with a particular focus on the role of firearms. He literally wrote the book, Guns and Suicide. So he's the guy when we're looking at this link of this uniquely American epidemic. And I'm also joined by Emmy Betz, who is a board-certified emergency physician and injury prevention researcher. She's currently an associate professor of emergency medicine at University of Colorado School of Medicine, where she directs the Firearm Prevention Initiative. Her areas of research expertise are provider-patient communication about difficult topics in injury prevention, and we know that guns and lethal means safety are one of those very difficult topics to talk about. And she co-founded the Colorado Firearm Safety Coalition, which is a collaborative effort between public health and medical professionals and the firearm retailers, which I think is really important when we look at this practice, is bringing the industry into it to better prevent suicide. She serves on multiple national work groups related to firearm injury prevention, and her research has provided funding to the National Institutes of Health, as well as numerous foundations. She gave a TEDx Mile High talk on firearm suicide, which I suggest you all check out. For Ones for Guns and Suicide, you can check out my recent TEDx talk too, and we could just start a great collaborative here. So as you can see, we're joined by a really, really exceptional panel, and I'm honored to be moderating this conversation with all of you today. So Arka, I'd like to start with you and start talking about some of these public health resources that are out there when we think about times of crisis and access to guns. And in particular, would like to talk a little bit about how access to these resources has changed in the time of COVID. Is there a different way in which people are actually accessing resources? Are we seeing more people reach out for care? Is there a lack? And as we start to navigate this reopening, what can we really do to ensure that people who may be in crisis are receiving the care and resources that they need?
Okay, so I appreciate that question. It's really difficult, and COVID has changed the resources a lot, especially the kind of resources where I work. I work in clinics and in the hospitals and the emergency rooms. So let's say it's sort of in normal times, like pre-COVID times, the resources for anyone in sort of psychiatric crisis is everything from sort of 911 resources to EMS, to going to hospitals, to ERs, to your clinics, and including and also community groups, community organizations, and so there was a lot of resources. And I'll just say how some of these resources have been affected. The clinics where I worked at in New York City, once the epidemic restrictions came in, clinics and hospitals are considered essential. We have to stay open, but our clinics suddenly went to a position where we said we want to reduce any clinic visits that we don't feel like we absolutely need to have. So clinic visits got canceled dramatically. Psychiatric clinic visits. And I guess I'll also weave in here that, working with severe mental illness, this means that people with sort of schizophrenia, bipolar disorder, complex PTSD, and major depression, those are folks whose visits got canceled and then rescheduled as phone visits or as sort of video visits. So those visits decreased a lot. ER visits also decreased a lot. People stopped going to hospitals. Ambulances would come to houses, and they would have maybe different. We've noticed one thing in New York: people would have sort of a different conversation when EMS would come to houses, respond to calls, and so EMS would often sort of say, well, they give it a little bit more higher of a threshold for removing someone to the hospital. Inpatient psychiatric beds, I would call that a public health resource. When you need sort of psychiatric treatment, the city, the country, we have psychiatric beds to sort of get you through that crisis for your safety. In a lot of places, including places where I worked, psychiatric beds just got sort of commandeered by COVID. And I'm not going to go into all of that, but the public health sort of resource of psychiatric beds decreased. And for a long time now, and still, the places I work, there are hospitals where, there's still sort of a 10, 20, 30% decrease in psychiatric beds. They're sort of that were taken over by sort of COVID care. And they slowly have to be sort of taken back up as the COVID surge decreased. Maybe more importantly, the resources that support us, support our mental health is the community, school, work, family, friends, and just the community supports us. For most, I realize that most of mental illness, what supports us is the people around us and who we're sort of interacting with all the time. And those are people that are supposed to sort of pick up on things when mental illness is getting worse, especially the severe mental illness I work with. So we try to pick up little cues like, slipping in school. We work with guidance counselors that sort of call us very early, long before we need a hospitalization. We work, people's spouses call us up, employers send people here. So those resources as well went from in person to virtual, and a lot of people sort of left their campuses as well. So a lot of resources got diminished. Nevertheless, now we're in a position where we're advocating more and more. From my clinic perspective and from our hospital perspective, we're advocating more and more that, okay, well, yes, COVID is in the system, Nevertheless, we need to still use an ambulance if we need to. We still need to, as in you need to call an ambulance and the person needs to come. I advocate directly for some of my patients to say, no, we're calling an ambulance now. They need to come to the hospital for this reason or that reason. In clinic, I'm advocating more and more, especially for my folks that are at risk of, of self-harm, of either psychiatric crisis or suicidal intention. More specifically, I'm advocating more and more for them to come in with family meetings. So I won't lie. So we're at that I'm at that middle ground where I'm like, well, I'm not at the Michigan State Assembly protesting Liberate Michigan or anything, but I'm sitting there saying, I need some people to come back in. We're fighting for that. The resources that have not gone away at all is, of course, EMS is there for you. Okay, so 911 is there for you. In most cities, 311, and in New York City, so that's sort of the city's agency's helpline. It also has something called 1888 NYC Well. That is sort of the emotional sort of support helpline. And again, our clinics, our city hospitals are open, and our city clinics all have options for how you can do a walk-in. And most of these hospitals as well, they have they have several sort of protective steps if you need to come to clinic, which means that they'll sort of take your temperature, that kind of thing. They'll try to keep things as COVID-free as possible. So we still need to use all those resources. The community is the other sort of, there's no sort of easy answer for that. The community still needs to come together in its ways, whether it's Zoom, whether it's sort of phone calls, however the community can stay together. But that's what I have to say in general, that COVID has sort of decreased our resources. We're trying to bring it back up, and we have to stay connected, especially for folks with severe mental illness. And I think I said a little bit, I might be rambling now, so I'll let it move on.
No, not at all. And I think that it's important to note that there are still resources available, but they've really fundamentally changed. And that change might inhibit, whether intentionally or unintentionally, some of those at the most critical state from actually accessing the care, because it's done in a different way. And it's done in a way that they're not used to, or their families and friends aren't used to. And I think where, Mike, I want to turn to you to discuss a little bit where we now have a situation where people are accessing care, even some of our most critically ill, accessing care in ways that they usually don't. And we've had this large increase in firearm ownership that's out there. We know there's just a lot more guns that are out in the community right now than were before we entered this lockdown state. Based on your research around the relationship between access to guns and the risk of death by suicide, what are some of your concerns, thoughts around this sort of change in how resources are developed, some of what might be barriers to care, or maybe some bright spots that we could see in maybe an expanded access to telehealth potentially? What really do you make of this based on the research that you've done?
So obviously the main point they hit on here is just when there's a surge on gun sales and there's an increased access and firearm access, particularly new gun owners. So it's not so much the person who's going from 7 firearms to 8, but the person going from 0 to 1. My concern is that there's an increased risk for suicide. And I like to be really clear about that and saying that acquiring a gun doesn't make someone suicidal. That's not what's happening or what we're saying, but when an at-risk person has access to a highly lethal method, and obviously a firearm checks that box, then the risk that they're going to die because of their risk goes up astronomically, right? So my concern is that you have a lot of folks who are sort of geographically dispersed who maybe have less access, at least to the resources that they're familiar with. And they're anxious, whether it's financial insecurity or housing insecurity or occupational insecurity, or the stress about we're opening things back up and maybe I'm not ready to do that, right? There's a lot of things that are causing all of us to be stressed. And when you pair that with access to a firearm, that makes me concerned, right? And so that's why a lot of us have been nervous. I'll also pair that though with a caveat, which is that I don't like that narrative to sound like because of this, definitely all sorts of people are going to be dying by suicide and the rates are going to skyrocket, right? So we don't want to make assumptions about that. It just means I'm concerned. And so we want to be proactive, just like you don't wait till the house is on fire before you buy a fire extinguisher, right? Let's plan for some risk, because when there's more firearm access, there's more risk, right? So to your question about what do I make about the shift in resources, obviously I'm not thrilled about that, right? I don't ever want somebody to have less access to resources, but to me, in a lot of ways, it's not fundamentally different than the situation is for a lot of folks at risk for firearm suicide in particular, because those times are not accessing resources when they are available, or if they are, they're sort of hiding their thoughts of suicide and not willing to come forward. And so I certainly love the idea of increasing access to things like telehealth and stuff like that, but I want to make sure we do it in a way that resonates with the folks who aren't typically engaging, right? So it's not just that I want to reconnect with the folks who were already comfortable with the way things were. I want to reach the folks who were never comfortable, so that they are engaging with the system and we have a chance to help them. Because the issue with firearms is that, unlike other methods for suicide, there's no second chance, right? So we don't get to find out they were at risk because they survive in an attempt, and now we get them integrated into a system. They don't survive the attempt usually, almost ever. And so we need to be able to reach out to them. But I also tend to spend most of my time on this side of things, Kai, thinking more on a preventive, sort of primary prevention approach, which is I want there to be resources, but mostly I want folks to sort of autonomously put a plan in place at home in a way that matches their values and reduces risk. And I just think there are a lot of simple things people can do, but especially those new firearm owners who maybe don't have a lot of experience with them and don't know a lot about safe storage and stuff might be less familiar with that. And so again, the message is always, hey, store your firearms unloaded, separate from ammo, in a locked location, like a gun safe or a lockbox. And I live in Mississippi, and I get the notion that a lot of folks own firearms for personal protection, and that there's a cultural value to that. And so I want to emphasize, I say, talking about this in a way that matches your values. I get that if you see this as a tool to protect you at 3 a.m. from someone breaking into your home, me telling you, well, that's not going to happen, leave it unloaded, isn't going to work, right? But there are a lot of things along this spectrum of safety you can do to make it harder for yourself or someone else who might be able to access that firearm to get it in a really difficult moment. And so I think that's the message to promote is, hey, try and reach out, and let's try and reach out to these folks in a way that they'll resonate with this and they'll connect with the system. But in the meantime, let's keep promoting this message of safe storage and noting that that does not violate gun rights and that does not diminish or demean anybody's sort of cultural vantage point. That this really is a collaborative thing where I think we all agree we don't want folks to die by suicide or unintentional shootings that happen quite often in the home, particularly when there's an influx of firearms.
Yeah, and I think that's so important, that message of education around safe storage before you even reach a crisis. As a longtime firearm owner and Marine, this is a big part of my conversations I have with folks all the time. I think, just based on sort of how I grew up, but I think having those credible messengers also reaching people in that way, which is why I think programs like End Family Fire is so important to things like this, because it drives the message home in a very empathetic way. And on that Emmy, I think Mike provided a very nice segue to talk about what this really looks like in practice. You've done a lot working with the firearms industry to help promote suicide prevention, lethal means safety, and access training around this. How during COVID has some of that work shifted, for you, where people aren't having as long of face-to-face conversations when they might be going to buy a gun for the first time, where a gun dealer can really engage them very well to talk about safety, and also to somewhat screen, to some sense, if somebody is thinking about self-harm. So when we think about this lethal means prevention, in practice in the COVID world, has any of that work changed for you, or are there things that really continue through from your work before?
So I think it's both. By way of a little background and echoing what Mike and Arka have said. So I'm an ER doctor. I'm a suicide prevention researcher as well. I live in Denver. I think probably like all of us, and like many people who are watching, I've lost friends and family to suicide, and still am in various stages of grief around that. And I think it's a really common thing that we don't talk about enough. But I also have lots of friends and family who are responsible, safe firearm owners, whether it's, hunting or time at the range or time with family. And I've been really thrilled to be working with the Colorado Firearm Safety Coalition over the past 5 years, which is a group I co-founded, and it really brings together the community to find sort of common solutions. Because I think, as you said, nobody wants to lose loved ones. And so, when I think about this as a clinician and really just as a person, it's really about how we help people get through tough times. So I think COVID has showed us, I think all of us, what it means to be stressed, anxious, sad, whether you want it to open up or not open up. Are you afraid of getting sick, not getting sick? Have you lost loved ones? Are you losing your job? Are your kids home all the time, bursting into your room? You know, like I think we're all recognizing mental health as a real thing in a way that maybe we didn't before. And so that I think is really wonderful. And so I think the next piece is really pre-COVID, but now as well, to help people understand that thoughts of suicide usually are temporary. People often talk about suicide as being kind of a permanent solution to what is often a temporary problem. And yes, some people have chronic struggles for sure. But when I think about firearm safety and suicide prevention, it's really about getting somebody through that tough time. So the analogy I used pre-COVID and the analogy I use now is it's like having a designated driver, right? It's not about taking away your friend's license when he drinks too much at the bar. It's about, although I guess we don't go to bars anymore. We used to go to bars, but it's about making sure somebody can get home safe, that they don't have access to dangerous things when maybe they're not quite thinking safe. And sometimes people say, well, but aren't they just going to find another way? And the thing is, we know that most people don't substitute another method. And the thing is, even if they do, it's less likely to be fatal. So that's why we focus on guns. It's not a gun control thing. So I think for me, as a clinician, and again, if I'm a friend, family member kind of stepping in, it's about breaking into two pieces. So one is really the education around what is this link, and especially for new gun owners, why do you need to worry about guns when someone is at risk of suicide? What is it you're supposed to do? And it's really about, as Mike said, locking things up in a way that is in line with your own lifestyle. So finding the choice that works for you. Our research group developed an online tool to help people kind of think through that. It's called Lock to Live. It's free if people want to use it. Because again, it's not a one size fits all solution. And then I think the next piece, which can be harder, but for me as an ER doc is a piece of what I think I should be doing, is how do we make it easy for people once they make a decision? And that's where there's a lot of interesting work going on now. How do we think about giving lock boxes or locking devices to people? How do we make it easy for people to store weapons temporarily out of the home, whether it's at a retailer or a range? How do we get creative about this so that it's not about confiscation? It's not about gun control. It's really about helping people keep their friends and family safe during rough times.
Absolutely. And those creative solutions, definitely something I want to talk about in a little bit, but we have a really good question from the audience. And again, I encourage all of you to ask questions. And this is one, because we have Arka on with us as a psychiatrist, I'm very excited to ask. And Arka, I want to kick this to you first, which is, how, and it's a little bit of a political question, but I don't think it's actually a political question, how do you square, really, there's been a lot of the very same elected officials who are big on promoting the use of guns to counter fear. We see these folks who are out there, that you need a gun to counter the fear that's in the world. Also are the same ones who are promoting more and more use of pharmaceuticals to address mental health crisis and issues. And we know that some of the potential side effects from some pharmaceuticals can be suicidal thoughts. And so you have individuals that at the same time are telling people to go get guns. These are people who are in positions of respect that people are seen as leaders, telling people to go get guns to take care of fears, but then also telling people to go ask their doctors to engage in behavior or their doctors for medication that may lead to thoughts of suicide. So as a psychiatrist and as somebody who's been really on the front lines of both the mental health crisis research, as well as a really strong advocate for known policies that prevent gun violence, how do you address this far too often, I think, sort of conundrum that we see out there? And what tools can you give all of our viewers to counter some of this rhetoric that we're seeing?
Sure. No, so that's an excellent question. So when people are asking their when leaders are asking us to sort of protect ourselves with firearms, and in the same way the economy, sort of the health pharmaceutical economy is saying, ask your doctor for this. It's why I think one thing we can remind ourselves every day, and I even tell patients this regularly, and I say, I work for you, so I'm here, so I'm an advisor for you. So just remember that you're an advocate for them, and everything out there is just a tool. Whatever you use to keep your home safe. If medications are necessary for what you're going through, that's just a tool. So I think there are a lot of providers in the audience, and there are a lot of folks that aren't providers as well. But either way, I think we have to remind ourselves, and if our provider, or remind ourselves in general for going to providers, the provider works for you just to sort of sort things out, kind of like a financial advisor. And really, they're just there to sort of figure out, what is the risk of taking this medicine? What is the risk of having a gun in the home? You really have to sort of be their, like I said, about to say financial advisor. You have to be their health advisor to sort of say, well, if you invest in this, this is how it's good for you, this is how it's bad for you. Like we bring up medications that could increase suicide risk. Like that's why when young people are started on fluoxetine, Prozac, you have to say, well, I think it's going to be helpful for you for these reasons, but the risk is this. Okay, therefore, if it's more helpful, then this is what we're doing. And if the question then comes around to, gun safety and sort of, now there's a gun in the house or nearby, I think, remember, you work for the person, as a doctor works for the person. So they should be the doctor, I think, should take it very technically saying, well, what is the risk of this or that if you have the gun in the house, not stored safely, or just having a gun in the house at all? You have to sort of go over a risk assessment with them. And then just sort of, what outweighs what? Do the benefits of having Prozac or something in your house, does it outweigh the risks, or are the risks too high? And just sort of, and if I can be a little mushy for a second, you're sort of there to sort of, to be their teammate, and to sort of just help them come to the best decision for themselves. And so in a way, I think, and I'll just say this, that I don't think you're being forceful in that sense. You're saying, okay, I'm your partner, I'm here to advise you, I'm here to take this information and say, okay, the medications are this helpful, and they're only helpful if they're working for you this way. Having sort of a firearm and firearm stored this way or available this way, is this helpful? In this way, it's not. So be their advocate and be their advisor, be in partnership with them.
Yeah, and I think that notion of partnership and advisor is so important when we think about how the medical profession can engage with individuals. We see this in a lot of other areas of healthcare. Domestic violence is one that comes to mind, where physicians have become much more, I think, active in being advocates for patients to walk through what solutions really are. And so, Emmy, sort of thinking about that, how do you approach helping other physicians sort of gain the confidence to talk about lethal means? Because it can be something that's hard. I think in the mental health community, there's become more of an acceptance that it's the role of the provider to talk about lethal means. But in the medical profession writ large, we know that the vast majority of people who end up dying by gun suicide have had some contact with a healthcare professional who's probably not a mental health care professional in the recent days. And so this is something that we really need the whole medical community to be aware of and understanding of. So what sort of tools and tips do you give your fellow physicians when it comes to having these are hard conversations? They're often seen as very personal conversations. People don't like to talk about being a gun owner. Like when I go to talk, it's almost like I feel like I have to be starting an AA meeting with like, hi, my name's Kyleanne Hunter and I'm a gun owner. And then it's to like put that out, but it's almost this like sense of shame I think people have about asking it, or concern if they're not a gun owner themselves and they ask a question, they might offend. So how do you start to arm physicians with the tools to have that conversation?
Yeah, well, I think you really hit the nail on the head there. I think the first thing is that we need to acknowledge that there is that stigma, and that we as a medical community often have perpetuated sort of judgment and stigma against people who own firearms for whatever reason. And I think it's tough. I think that there's a balance. I think we do have a role 100% in being advocates for safety, for, as Arka was saying, for sort of decision making about weighing risks and benefits. But I think we need to start by recognizing that politics and our own personal cultural backgrounds, religious views, et cetera, have no place in the exam room. And I think we're really used to that on other topics, whether it's sexual orientation, sexual behaviors, sort of religious preferences around medical care and so forth, blood transfusions or not blood. We're trained to be sensitive and respectful of those. And I think we're catching on now to firearm ownership as being something that we need to be respectful of. And so, I think there's some great trainings out there for clinicians that we won't go into today, but for clinicians who are interested, there's lots of stuff available now that has come out over the past few years that really can help people walk through almost role playing what these conversations look like. But I think the first step is to kind of check yourself and figure out where your own biases lay and where your questions are. The second step is to practice, in the same way as a medical student, I was trained to practice saying, do you have sex with men, women, or both? And I was really giggly at first, but then you just get used to it. And now I don't think about it. So you have to train yourself, you have to practice. And I do think the third piece is to recognize you don't have to be an expert. Like, I don't need to know all the ins and outs of the latest safe or locking device, or I would even argue I don't even need to know the differences between various kinds of handguns and so forth. It's about knowing the principle that there are a lot of solutions out there that a person can find, and then knowing where to refer them. So what resources are there? Maybe you can have handouts for people and so forth, but it's more about having the being really open and honest about why you're talking about it, and then offering to help, being a teammate for sure, and then referring people to where they can get more information.
I think that's really important, this notion that you don't have to be an expert to help people get to the next stage of safety that they really need to be able to get to, and being open and honest. And we do that on a lot of issues. And so, Mike, a lot of your research also draws from other areas, whether it's other areas of suicide, other areas of hazard, and sort of correlates what lessons we can learn for gun suicide coming out of how we've successfully addressed some of our other problems out there, including research that just came out this week with Emmy here. So what are, I think, some of your big findings that you can say, like, from other areas of potential harm, you feel like, yeah, we can actually draw really important lessons, and we're not doing this very well with regards to guns and suicide. If you want to do research too, here's the
So, I'll circle back at the end to the paper you referenced that Emmy and I just put out. Thinking about what we've been doing, and I think it builds up of what both Akra and Emmy were just saying. I think a lot of this comes down to salience, is what the research has told us, is that first of all, firearm owners are a very diverse group of folks who live in different places and view firearms differently and own them for different reasons, right? So I want to be careful not to slap a "this is what all firearm owners think" label on them, because that in and of itself is going to make us lose all credibility. This is not one homogenous group of folks, right? But in the people who've come through our studies who tend to store firearms in a way that I would call unsafe, and who seem less open to changing, a lot of it, our research shows, comes down to a sense that this isn't relevant, right? That suicide is something that happens to other people, and that firearms aren't related to suicide. So what's the point of making this change anyways, right? And so I think a lot of the work ahead of us involves just sort of increasing folks' understanding of how these things are connected, but also in building off of what other folks were saying on the panel, extending these conversations outside of the healthcare system too, so that they're normalized and they're more frequent and more common. So in addition to healthcare professionals knowing how to talk about this, I want faith leaders to know how to talk about this. I want educators, I want law enforcement, I want folks who are frequently in contact with populations of folks who own firearms, who can then credibly speak to this issue in a way that resonates with all the different cultures embedded within what we would call firearm owners, right? So the research, what it's showing me is that, I'm probably not the guy who effectively delivers this message. And that's okay. I'll talk about it to people who can more effectively deliver it. And we need to learn more about who those folks are and how best to deliver it. And a lot of that involves actually engaging with these communities more directly and not making assumptions from our own vantage point. In terms of the research that just came out, where we're going with it, I guess I'd also, in some ways, sort of surprisingly urge caution on some of the messages that we're promoting too. And so what Emmy and I were talking about was that you can draw lessons from the successes in pesticide suicide prevention in Asia, where you saw massive, just massive, we're talking like 50% reductions in suicide rates in countries that were having a really difficult time with pesticide-related suicides. But what they found with that particular method was that safe storage methods weren't all that effective. Actually, it came down to banning, right? And so this is not me saying, so haha, we need to overturn the Second Amendment and ban firearms, but it is to say that let's not get ahead of the data, right? Let's actually study these things and find out what works. Is it a certain type of storage? Does it need to be storage away from a home during times of stress? And if so, how can we do that in a way that doesn't take away autonomy and creates a sort of menu of options that both map onto legislation that's in place, but also map on the folks' values and doesn't necessarily require people to say, hey, I'm suicidal, which they're not going to do. And so I think what we were urging was let's make sure that we don't, in our efforts to find common ground, we don't get so far ahead of ourselves that we then promote the wrong things. And let's actually study what does and does not work. And that's hard to do, but I think it's really important because we're also going to lose our credibility if we go too far with one message and find out that wasn't exactly the right message.
And I think that's actually so important, actually leads to another really good audience question that we have, is this notion of, it's been really hard to study this issue. And some of it is because so often whenever anything about guns comes up, and guns in any matter, it's automatically assumed to the fact that, well, you hate the Second Amendment. You want to overturn the Second Amendment. The second you start to engage in the fact that there might be a risk associated with a gun, it becomes this sort of black and white, all or nothing. And so I think for Arka and Emmy in particular here, do you see this also as a barrier for physicians being more engaged in these conversations, because they've been far too often framed as, anytime you bring up anything to do with guns, it's automatically you hate the Second Amendment and you want to overturn the Second Amendment. And that lack of nuance in both the popular conversation, but also in a lot of the research. And I think to Mike's point too, around not all gun owners are the same, most research out there, it's very binary. You're either a gun owner or not a gun owner. And that doesn't really get into the nuance as to why people own them, what part of their identity is. It has been very binary too, as well. You either support the Second Amendment or you hate guns, it's been framed very much on the other side. So has this bled over into the physician community?
So yes, I think it has, but I also think it's changing. I mean, I think I'm ever the optimist. So it feels though like over the past few years, there has been more discussion about the fact that I think the vast majority of people are somewhere in the middle, right? There are lots of physicians who own firearms. And many of them still support counseling and maybe even various forms of legislation and are not sort of on one extreme or the other. And I think opening up conversations within the profession, and by the way, when I say physician, I'm talking about all healthcare providers that who might interact with patients. But I do think that has been a fear for some providers in bringing these topics up, that they don't want to offend patients. They don't want patients to think that they're advocating for gun control, for example. And that's where I think some of the new trainings are really helpful in giving people the background and the tools that they need to talk about it. In a way that, as Mike alluded to, it's really about framing the messages and the education so that it is acceptable and meaningful to people, so that people don't just kind of shut down. I think what's been really exciting for me to see too is not just that we are finally getting more funding for research, that NIH and CDC this year have big new influx, but also I think that I'm seeing an increase in sort of thoughtful, collaborative proposals of people who are really engaging with various groups of firearm owners early in the process to help design the research, to develop tools that are useful for that population. And hopefully then the findings and the final products from that kind of research provides the evidence base that we need, as Mike said, but also helps with the credibility and the effectiveness once it gets out in the real world, that it is actually an effective product that might change behaviors, but more importantly also feels really authentic because it came from collaboration with that community. And so I think that's been really exciting to see big, whether it's small partnerships, local partnerships working together, or some larger national kind of efforts of groups starting to really find that common ground and answer questions together. So it's not just the questions that the physicians want answered, but it's also the physicians, the questions that, the average firearm owner might want answered too. So I think we're headed in a good direction.
Oh, I guess, so I'll say that I think that docs are in a position where you don't have to be pro-gun or anti-gun. I think you can be pro-safety and pro-patient and sort of make your conversations that way. Again, I'm in a privileged position as a psychiatrist. I can concentrate on mental health, and we have to do, safety assessments and risk assessments. So we have to put together all this. Well, you have this diagnosis. This happened at this time. This is how close you are. So then I can sort of, it easily weaves in. Is there a lethal means to this? We just had a tough conversation. At first, it was tough, but then it wasn't so tough. We said, well, it looks like you shouldn't have so many pills in your medicine cabinet now that since this overdose has happened. And, that we have to convince ourselves first, but we get there. This isn't punitive. It's just in your environment. We're just pro safety until we get past the crisis. So again, I think safe storage is can be the same thing. And again, as a psychiatrist, I'm a little spoiled, and mental health workers, we're a little spoiled because we have the time specifically spelled out to do that. In primary care, which is where most people get their physician contact, and most of the mental health in the country is done in primary care. They're not given as much time, except for the really great systems where they can weave stuff in. But I really think that in primary care doctors have to be anti-gun, pro-gun. They can be pro-safety, pro-patient. And I think the conversation about safety in the home, I think the gun just weaves in. I think safe storage just weaves into, do we have fire alarms? And are there smoke detectors? When you have a toddler, have you sort of put in all the appropriate sort of controls in there? And then the sort of safe storage just becomes part of the conversation. So I think that's where I just feel like from political, right, left, or pro-gun, anti-gun, I think you can just become pro-patient, pro-safety, and weave it in. And I think even in primary care folks, when they're really challenged in their 15-minute interviews, I think they can make sort of a firearm safety part of home safety, and keep it apolitical that way.
And that's a really important point, this notion of sort of weaving it into other things that are safety, fire detectors, carbon monoxide, how you store the booze in your house. If you've got kids who are there, like whether it's toddlers who just want to put everything in their mouth, and so they might try to do it, or teenagers who might be a little more nefarious trying to get it. That conversation is not a anti-alcohol conversation. It's a pro-safety of your family conversation. And so I think that leads to a question that we get a lot, and several people in the audience have brought it up this time too, is that when you're having these general safety conversations, which we all say, that gun safety is part of just safety. Do you have a fence around your pool? Those sort of things too. Do you assume that all of your patients have guns and just ask them as part of a general sort of battery of these are some like general safety concerns, or do you specifically ask people if they have guns? And I think and then the sort of second follow on to that is for the general sort of population that's out there, we always encourage people to ask about guns in the home. And during this time of COVID in particular, we've been encouraging people to ask their loved ones who might be in distress about guns. Is it better to just assume that you have it to normalize? So the question really becomes, how are you storing them versus do you have them? And is that question different in a clinical setting versus a social setting?
If I can say one thing, I'm glad that we've already brought up, I believe Mike brought up, that there are just a lot of new guns in homes out there right now in the last 2 months. So I think we have to ask it sort of in a general sense now. Are there, for me, again, I'm a little bit spoiled in mental health. I can ask if there's, is this risk for harm, that risk for harm, and I can ask, could there be any weapons in the home? And I think we're allowed to ask, are there any new firearms in the home, even if it's a family we already knew, because there are a lot of new firearms in homes right now.
Yeah, and what I would say that it really depends on the context, not just clinical versus kind of with your friends, but also why you want to know. So I will say I'm a parent. When things open up again and my kids go over to play, I usually ask things like, do you have any unlocked guns in your home? So it's a question. It doesn't assume they have them, but kind of assumes, and it's really getting at what I care about. I don't really care if they have guns as long as they are locked up. I think it's different when someone is acutely at risk of suicide. And really for the general public, that means if you're worried somebody seems down, depressed, off, drinking more, there are lots of sort of potential risk factors or things you might spot. I think, as Arka said, sort of picking up the clues that someone might not be doing well. That's, I think, where you really need to get into a more explicit conversation about like, hey, how do we make your environment safer while you're going through this time? I usually talk about both firearms and medications, because medications are important too, but it also broadens the conversation a bit so that people don't feel like the guns are picked on. And so if I have a patient, I will ask it specifically, do you have guns in your home, or do you have access to guns? How about medications? But it's really different if I'm in the ER and I'm seeing someone with an ankle sprain who is not having a mental health problem. We don't talk about firearms because it's not really the right context. A pediatrician may have more of those conversations, but I think it's important. I always want to emphasize that I am not advocating for universal screening for firearm ownership in hospitals and ERs. Like, there's no evidence that that does anything. And so I think we need to be having these conversations in the way that is appropriate to the context, and it's clear why you're talking about it and what the information is for.
And Mike, you know, given the really extensive research and especially focus group work I think you've done around gun owners, like how does this really play out? Or if you had something completely different to say, that's also good too.
No. I mean, I think that building off this, I think that, you know, Emmy's mentioned that context matters is important, right? So what you would say in a doctor's office, someone who's acutely suicidal, is different than you want to message in general. Yeah. So I mentioned earlier, there's folks who don't want to tell you if they're suicidal. And my friend Craig Bryan has pretty compelling research out there that also there's a lot of folks who don't want to tell you if they own firearms or not, right? And so just asking that question doesn't tell you much. Sometimes, especially because what Craig has found is that the folks who are hesitant to answer look a lot similar, like very similar to folks who do say they own firearms, but often more suicidal, actually. And then similarly, we know that suicidal folks aren't more likely to own firearms, but if they do, they're more likely to store them unsafely, right? And so if somebody is hesitant to talk about their suicidal thoughts or behaviors, or if someone's hesitant to talk about their gun ownership, there has to be a context in which we have given them this information anyways. And it probably isn't when all the alarms are going off for them because they're in the doctor's office and they're acutely suicidal, because that's a harder moment to reach someone. That's why I think that, again, context matters, because there's a situation where ahead of even being in that situation, we need to have normalized the message of safe storage, and we need to increase the scope with which that's delivered so that people encounter it frequently enough that they internalize it, so that they are not forced to answer questions that they don't want to answer. And we're not forced to get honest answers from those questions in order to be able to help them, right? If we all wait for that moment to ask that question, we're going to miss so many people. That's, to me, what sticks out.
I would just love to really emphasize something Mike said, this idea of how do we normalize these conversations before people get into clinical settings. Again, like the friends don't let friends drive drunk kind of analogy. How do we really make it around that you look out for your buddies and your family members, and if someone's having a rough time, you take steps to call or get them the mental health help that they need, but you also help them lock up guns, make sure the environment's safe. How do we normalize that piece? And the sort of the friends don't let friends struggle alone kind of message, I think, is really important. Mike, thanks for bringing that up.
Yeah, and I think that segues like perfectly into what will be our last question here, which is, you know, we talk about context mattering a lot, messengers mattering a lot. So I like everyone here, if they could give an example of a particular instance where they were working with a community where this conversation worked well and why, or an intervention worked well, something that they see as a positive. I think we talk a lot in sort of, context matters, credible message matters. Like, I think it would be really great if we could throw out a few concrete examples of, here's a time that it's really worked, and this is why, I think at least why it worked this way. So anyone who wants to go first, like jump on in here. All right, Arka.
Sure. Okay, so I guess one of the things I'm lucky to do here in New York is either do community mental health sort of workshops, and it's really just educating folks on signs and symptoms of any common mental illness or severe mental illness, or when to extend more support to your family or loved ones or coworkers. And I've done that in the venues of either sort of public libraries or at sort of youth programs. Something in New York that's wonderful is called The Door, but these sort of organizations. And I guess the question is, how do we sort of start the conversation, and how do we find success? I think it's like about being proactive, just like how Mike and Emmy were saying, well before the crisis. Become part of your community, as experts, and sort of go out there. You don't have to do these workshops, but sort of the truth is the community wants information. So people are very sort of into knowing everything I could sort of say about, why not to be afraid of severe mental illness. Don't be afraid to ask the questions, and how do we sort of get people to crisis help, aid for crises. And then honestly, sort of guns is part of that gun safety, safe storage, that kind of thing. That becomes a question that comes up in these workshops as soon as you do 1, 2, or 3 of them in any community. So it just becomes a part of a larger conversation about community wellness. And I think that we're having success as long as people show up to our events, quite honestly. So that means that the community cares and we're doing something effective for them. And now they know how to get to us or to other resources. And again, firearm safety is just one small part of that whole conversation, but it's in there, and they want to know. And I think that's success.
I'll share, I think the thing that I'm probably the proudest of that our research group has done. We worked with the Colorado Firearm Safety Coalition and really firearm owners around the country, as well as people with prior suicidal experience, to develop Lock to Live, which I mentioned earlier, which is a tool that's free online. We're not making money off of it. It's locktolive.org. And it's a tool that helps people think through sort of everything we've talked about today, understanding why you should be locking things up, but then making choices that make sense for you and your family, both in terms of firearms and medications. And with NIH support, we tested it in a trial in 3 emergency departments in Colorado with adults who are suicidal, adults who are suicidal and own firearms. And what made me the happiest was that I think it was 100% of people said that the tool was respectful about their views on firearm ownership, and that they would recommend it to someone who is in a similar situation. And that to me says that we got the messaging right, at least for this context, that by incorporating the views of people early on and really getting a lot of feedback in the development process, we made something that works, at least for a lot of people, maybe not for everybody. But I think that potentially speaks to the power of, again, engaging early and being thoughtful about the specific words that you use.
For me, I think the example I draw from the most is my group is wrapping up a clinical trial of lethal means counseling. So conversations about safe firearm storage with firearm owning members of the Mississippi National Guard. And so these folks on average own 6 or 7 firearms, and there's not a lot of safe storage going on ahead of time. And on the one side of it is that our retention rate, 95% of the people come back for their appointments, and 100% say they'd recommend it. So that's great. It means that we're not saying things that offend people, but to sort of anecdotally give a sense of how I think it's worked. We've had folks who've come in and said, look, this is a bunch of BS, and I'm not going to do any of it. And our response is, well, thank you for telling us. Like, we understand your perspective, and I appreciate you coming in and talking to us. And people view things differently, and I just, I appreciate your time. And those folks have come back, and some have been like, guess what? I still didn't do it. And again, we're like, okay, again, I appreciate your time. It's helpful. But some of those folks have come back for their 3rd appointment and say, hey, I broke up with my fiance, and I thought about the conversation, and I gave my firearms to my brother to hold for the time being. And so I often tell my clinicians, it's about planting a seed. It's not that you're going to have this conversation and magically everything changes immediately. It's about being respectful and patient. And when people feel heard and not pushed to one corner, they might be more responsive when things emerge. And it's important to note with this trial, people aren't coming, some of them are relatively suicidal, but we're not seeing people in a clinical moment. We're seeing people just in general as a primary prevention thing. And so you can say these things to folks, again, before the house is on fire. And if you do it respectfully, when that moment comes, they may become open to things because it becomes salient to them then, and nobody forced them to do a specific thing.
Yeah, I think that's so key. I know you had the members of the National Guard, but like as a veteran, and as somebody who has been suicidal and is only here today because I had early intervention work and had someone who was actually able to say like, no, we're actually going to take your guns out of your house right now because you're in a place where you shouldn't have, and in a place where that was possible to happen. You know, this early consistent conversation is what's so important, because in that moment it also made me realize it was the right thing. It didn't feel like it was something that was getting forced on me in a, you know, by something, but part of a process because people cared. And I think the other big thing, and it's been really important in the veteran community, but I know for a lot of gun owners with this, is a recognition that there's a lot of positive association with guns from people who might be the most at risk of harming themselves with guns. You know, for veterans, it's the sense that a gun feels very much like a security blanket. It's the thing, the tool that may have saved our lives downrange several times. And it's hard for us to cognitively understand that it's also the thing that may end our lives. And so having these open, respectful, nuanced conversations early on helps. So I think in that moment, you know, being part of the community, as Arka really said, embedding yourself as sort of one of them non-judgmentally is what is such an important part, because suicide, when we think about gun violence, really is the piece of gun violence that we need to engage directly with gun owners as people on in order to prevent. You know, there has been a lot of really great questions about legislation and resources, and we'll put all of those in the Facebook comments around what those options are. But I really wanted to focus in this last question on that human community engagement aspect, because that person-to-person conversation, the early intervention, normalizing these conversations early on, so that in a moment of crisis, it doesn't feel like a hard conversation that's coming out of the blue, is so important. So on behalf of Brady, behalf of Doctors for America, I really want to thank all of our guests. If we were here in person, I would have everybody give a big round of applause. We're not, but it also allows us to be in 4 different states and have this conversation at the same time, which is one of the, I think, great things, to be able to get this such esteemed group together in one place to do this. Thank you for continuing to be on the front lines during this crisis right now, where we're dealing not only with a virus, but with some big potential mental health issues coming up and a surge of guns. I mean, you all are a model of what this work should look like. So I greatly thank you. I know everyone who has participated, thank you. And on behalf of the panel, thank all of you for joining us today and your wonderful insights. Please stay safe. Please follow Brady and Doc for America on social media to continue this conversation, and we'll make sure that the panelists stay engaged to answer any of the other questions you have. Stay safe, everyone, and thank you so much.